My name is Heather Ciccarelli. I'd like to welcome you to this webinar session brought to you by the Patient Navigation Capacity Building Initiative. The focus of this session is social determinants of health screening, navigating to address barriers. I am delighted that we have a special guest speaker this afternoon, Dr. Abdul Said Calvino. And Megan, if you would advance the slide for me. Just a reminder, this is on Zoom. This meeting will be recorded. The recording will be sent out to you later this week. All of the participants are muted and you will not be able to come off mute. We'll be utilizing the chat and the Q&A to answer any of your questions this afternoon. And we also would like to thank our sponsors for their support. There's a slide at the end acknowledging our sponsors, and I'll make sure to call them out specifically. But without further ado, I'd like to welcome our keynote speaker. So Dr. Calvino was highly recommended today to talk to us about social determinants of health screening. He has a passion for screening folks for cancer screening, and is going to share his passion today about how navigation can help address barriers to care. So Dr. Calvino completed his surgical internship and residency at the University of Illinois at Chicago. He also completed a 2-year fellowship training program in complex surgical oncology at Roger Williams Medical Center in Providence, Rhode Island. He is an assistant professor of surgery at Boston University School of Medicine and is certified in general surgery and complex surgical oncology by the American Board of Surgery. Dr. Calvino has a special research interest in cancer care disparities. He spearheaded the Roger Williams Cancer Center Surgical Community Outreach Program, focused on creating cancer care awareness and education of the Latino community in Rhode Island. As part of this program, a culturally oriented colorectal cancer screening navigation program was implemented to decrease colorectal cancer disparities by overcoming cultural and language barriers to care. The program has been very successful, helping over 700 Hispanic patients to get screened for colorectal cancer in Rhode Island. This program has been recognized by multiple local organizations, including the John J. Cunningham Award by the Rhode Island HCA in 2019. He has also obtained national recognition, receiving the Lane Adams Award by the American Cancer Society and the Carol Friedman Award by the CDC. We are absolutely delighted that you were able to join us today, and we're looking forward to hearing what you have to say. And I will turn it over to you. Thank you so much.
Thank you. Thank you very much, Heather, for that introduction. And it's a pleasure for me to be able to talk to you a little bit about a topic that is not a topic that you usually will expect a surgical oncologist to kind of be involved with. My path was a little bit different. So I'm Hispanic. I'm originally from Panama, and a lot of the patients I was seeing that were Hispanic were presenting with more advanced disease, and that's how everything started. I said, you know what? Let's see if we can help more people instead of helping just one in the OR at a time. Don't get me wrong, I love to do surgery and I still do it. I just came from the OR. But I think there are ways that we can help the population and help more people to certain interventions. And some of them are the ones we're going to be talking about today. We're going to be talking about patient navigation and how we can use patient navigation to decrease health disparities. How can we identify those social determinants of health that we so much talk about and that a lot of you know a lot about, but how can we make that actually a tangible thing to measure, to capture, and how can we create an intervention that can actually help? And that's what we're going to be talking about. Next one. And this is an outline of one of the things I'm going to go through today. I'm going to give you a little bit of a background. I think it's important that we're all in the same page in terms of social determinants of health and health disparities, how to identify them, what are the barriers to care that we should be looking for, real life impact of health disparities, the role of patient navigation, not only screening for health disparities, but then afterwards, creating and designing interventions that can help us and help the patients, our patients. Implementation and impact of navigation programs and lessons learned. You can go back. Oh, nope, there. So next one. Yeah. So the first thing we need to do is pretty much define what health disparities are. And this is, again, something that you all are familiar with. But we need to understand that so we can always go back to that as we create interventions as we look into this. Right? So the National Cancer Institute defined health disparities has differences in incidence, prevalence, mortality, burden of cancer, if it's cancer, what you're looking at, and related adverse health conditions that exist among specific populations groups in the United States. So we understand that there are specific groups that behave different, that have different outcomes, and that their health outcomes, incidence, and prevalence of cancer is different than others. Now that we know that, now we need to try to figure out how we're going to identify those groups and how we're going to help those groups and who are those groups. Next one. We can't talk about health disparities, social determinants of health, if we don't talk about Sir Michael Marmot, who is from England. I had the pleasure of meeting him actually in Boston 6 years ago, was 6 years ago. In his time in the early 1980s, in England, there was this conception that all the business people that were very stressed about big business decisions and money making businesses would have a higher incidence of heart attacks. Until Sir Michael Marmot started thinking, is that true? Is it true that heart disease is more common in this group of patients or in this population? And he pretty much designed a Whitehall study when he looked into very high level businessmen and women and compared the incidence of heart disease with the lower socioeconomic levels. And what he found was not only that the higher socioeconomic level had less incidence of cardiac disease, but that there was a gradient of health. The more or the higher your socioeconomic level, the less incidence of cardiac disease. And that's what created the term gradient of health. And then from there, we start talking about, well, what are the determinants of that gradient of health? Is it socioeconomic? Is just the financial aspect and many other things that we're going to define later. But Sir Michael Marmot was the first one who actually pointed out that there is the difference and that the people that has a higher socioeconomic level do better. And that's true not only for cardiac disease, which is what he looked at, but also for cancer and many other diseases. Next one. In the United States was later in 2003 that we started to have some reports, Institute of Medicine report that starts saying, well, not everybody does the same. We do have some ethnic groups that do different. Their outcomes are not the same. And then they start looking into those ethnic groups that at that point were called minorities, then they were called underserved populations, because we started to realize that it wasn't only the economic part or the social aspect, but there were multiple factors. And then we started to learn a little bit more about it. Next one. In 2013, the Department of Health and Human Services put out a report, as well as the National Healthcare Disparities Report was put out by the Department of Health and Human Services, as well as the National Healthcare Quality Report. And in those reports, pretty much they said, okay, there is definitely a gap. There is a disparity in health, and the quality that some groups receive is not the same as others. In summary, healthcare quality and access are suboptimal for what in that time we call minority groups or low income groups. Next one. The good thing about those reports was that at that point, and a lot of groups started to actually, well, if with these reports, we have evidence that definitely there is a gap in care, there's a gap in outcomes, there's a disparity in outcomes. How are we going to deal with this? So then we started to have some funding, we started to have money going into figuring out what social determinants of health we needed to identify, how we identify them, and what we're going to do with that information. One of them obviously was education, and that's one of the reasons we're here today. How can we identify that group of patients? So we now know about social disparity of health. We know there's a group of patients, but how can we identify that patient when they come and show up in our clinic as an individual? And that's the part that we want to kind of talk about. Next one. We have to screen. We have to screen for what we call high-risk patients, of patients that will be at higher risk of receiving less quality and with worse outcomes. What we look for is 5 things. One is economic stability. Is that patient unemployed? Housing, poverty, mostly income. We also look at educational level, language, literacy, cultural background, health insurance. Does the patient has access to care? Where do they live? And we do that through zip codes, neighborhood, environment, and social context. Do they have a family? Do they have kids? Do they have support? Are they incarcerated? All those things and those 5 kind of levels are very important. And then what we're trying to do is, how do we capture that when the patient comes to us? Next one. We have to start seeing the patient not only has a patient with a specific disease, diabetes, hypertension, or come with cancer. We have to see the patient has a social person who might have some risk factors associated with his employment, with his educational level, with his income, with the neighborhood where he lives. So we need to start to change the perspective of how we see the patient and start capturing those other factors. Next one. So how do we collect that information? So something that in the last 5 to 10 years we have been able to do is to adapt our EHR, or electronic health records, to capture some of that information. The way we do it, and we find this in our clinic very easy to do, is that when the patients come to our clinic, there is an MA that usually gives them a paper that they have to fill out with allergies and other things. Well, in that time, we also have a survey that will ask questions regarding the different factors that we just talked about. So we obtain information at the point of contact with that patient. This could be done in any clinic, anywhere where the point of contact is done. Then you have a survey, and this survey can be personalized for your community. If you see a lot of Hispanic patients, then you want the survey to be in Spanish. If you see a lot of, happens to us, Portuguese patients, then that survey needs to be in Portuguese. So you can kind of start personalizing that survey or your tool, the tool that you're going to use to collect, depending on your population. And then with that, you do a risk assessment. So what happens usually is that the MA will have the survey. That survey will be filled out by the patient. And then from there, it goes to the electronic medical record. And then it could be flagged, so the social worker can look into it and see what the different risk factors are and how they can help. So there's kind of integration of that information into our medical record system. And then you have the evaluation by the social worker or other trained staff, sometimes non-clinical, like a navigator. And that's where you capture the patient, and then you have the navigator work with it. In the last, again, 5 years, we have been able to actually get coding. And in the ICD-10, we have what is called the C codes that go from the Z55 to Z65. And you have different codes for those social determinants. So now you not only can capture the information, put it in the EHR, but also you can code it, because you know that patient is a higher risk. So why not, knowing that the group of patients you're seeing are already a high risk group? And the best way to do that is if you can actually code that as a diagnosis. Next one. And this is an example of, for example, C55 is a C code category that will code problems related to educational literacy, 56 problems related to employment and unemployment, 57 occupational exposure to risk factors. So you can actually code that information that you are capturing. Next one. There are leading health disparities issues. So you might need to, in your clinic, identify what's the leading problem. Am I in a clinic where I'm going to be seeing with multiple patients with multiple medical problems, hypertension, diabetes, renal problems? Is it a cancer clinic, like in our case? Is it cardiovascular disease? So you have to pretty much decide which is your leading cause. And my recommendation is just to kind of focus on one thing that you want to capture and you want to get information so you can have metrics and you can work on that specific area. Next one. In our case, we do that with cancer. Next one. In terms of cancer, there are certain things that we want to look at in our community: incidence or prevalence, which that's mostly related with the biology, and screening too. Outcomes: do our group or a population do better, worse, gets diagnosed with a more advanced stage? Quality of care that they receive, type of surgery, stage at diagnosis. That's one of the things that we look at a lot. And prevention and treatment and adherence and completion of the treatments. When you're dealing with cancer patients, they have to complete chemotherapy in some cases. So making sure that they actually adhere and finish the treatments is also very important. So you need to have metrics. What are the things that I'm going to look for, that I'm going to measure once I have identified those patients and that I have a specific intervention design? Next one. And you're going to identify several barriers. And again, those barriers are going to depend on where you are, what resources you have, what neighborhood are you in, what community. And then you can start kind of categorizing those barriers. In our case, in terms of cancer and specifically colorectal cancer, we have personal family, what we call personal family barriers. We have structural barriers and financial barriers. In personal family could be the language or cultural aspect. If you are dealing with a Hispanic patient or African American patient or a Southeast Asia patient, the culture is very different. So you need to make sure that whoever is dealing with that person, could be a navigator or your MA, has that language and cultural sensitivity. That's a barrier that you're going to have to overcome. It could be also structural barriers. They cannot get to their appointments. They're not organized. They have multiple appointments and they cannot get to all of them because they don't even remember which appointment they have every day. And believe me, it can get really, really hectic. I'm sure you all know that. Financially, if they don't have insurance. So now you have a big barrier. How are we going to make sure this patient has access to the care he needs? And then based on that, you can start using services. The social worker is one of them, or then preventive services, diagnostic services that you might need, and use, if you have them, navigators, which I think play a very, very important role, because the navigators not only educate, they actually can overcome a lot of these barriers. And initially we thought, maybe the physician, the clinician can talk to the patient. It doesn't work. They don't have enough time to see the patients they have to do, and will not have time to deal with all the logistics around this. But a navigator working in conjunction with a clinician is a great combination. So that's why the role of the navigators is so important. More if it's a cultural and language sensitive navigator. Next one. In terms of disparity of cancer, which is the one that I'm using as an example, ethnicity is one of the main factors that will create certain barriers to care. Next one. Disparities, as you know, are the result of complex interaction. It's not just one factor among multiple factors. For example, you do have the biological. If we talk about cancer or hypertension, diabetes, there is a biological component where hypertension or diabetes is just inherently worse in a specific group of patients. The same way, for example, cancer is more aggressive in Caucasians than it is in Hispanics. So there is a biological part of the disease that there's not too much we can do about that part. But there's some socioeconomic aspects. For example, access to care is one of the most important ones. If you don't have access to screening tests, you won't do it. But even, and we have data about that, even if you have access to care, if you don't know, you're not educated about those preventive measures, you won't do it neither. Or if you don't trust the provider, you don't trust the person who's communicating with you, or you don't understand it, that's when we get into cultural and language barriers, then you won't do it. And then the result is going to be worse health and outcomes. Next. And we have a lot of, as I was mentioning, we have a lot of data and information. In terms of cervical cancer, for example, we know the highest incidence of cervical cancer is in Hispanics, Hispanic whites. And we know that's related a lot with the fact that they don't get the vaccine and depending where they are. But there is a huge disparity on cervical cancer in Hispanics. Colorectal cancer, we know African Americans have the highest incidence rates of colorectal cancer among all races. They do the worst and they have the highest rate. And we know a lot of that is secondary to biology and to prevention of colorectal cancer and screening. Next one. Breast cancer, African American women do the worst across all ethnic groups. You can compare with whites, obviously, Asian, Native Americans, Hispanics, they do the worst. So we know there is a gap in breast cancer. And again, part of it might be biological, but most of it is secondary to barriers to care. Behavioral risk prevention as well is one of those that we see in American Indians and Alaskan Native is higher. Next one. There are certain things that might help, and one of those things is workforce diversity. Having a diverse ethnic group among physicians and navigators is very important. More if you are in a community that see that group of patients. Next one. And cultural sensitivity is also very important. You could train people and you can train your staff to be culturally sensitive. It's not the same, but at least you need to make sure that the person who's going to be dealing with that high-risk patient and that high-risk population not only have the language barrier taken care of, but also they are cultural sensitive to the group they are attending. Next one. And what are those groups? Well, we know Blacks or African Americans, Hispanics, American Indians and Alaskan Native, Asian, Southeast Asian patients. Those are kind of the group based on the ethnic group. But in general, any patient, Caucasian or with any ethnic background from a low income or underinsured or underserved population will have a gap in care and their outcomes will be worse. Could be also based on age. We've seen that a lot with geriatric patients, older patients, immigrants. Again, patients who don't speak English, they become a problem or a burden for the system because they go to a physician, the physician can't talk to them, they need an interpreter, and the interpreter helps a lot, but it becomes a problem. So having workforce diversity is very, very important. Once we identify the groups of the high-risk population we're working with. Next one. Now let's talk about real-life impact. So now we know what social determinants of health are. We know health disparities. We kind of understand all this, but okay, how does that comes to real life when you're dealing with a patient in the clinic in your daily activities? Next one. And for that, I have some cases to illustrate. These are our cases. These are real-life cases. We have a 55-year-old male Hispanic from Guatemala. He's a construction worker, married, has 2 kids in high school, suffer of obesity, which is very common in that region of Central America, Guatemala, Mexico. borderline diabetic, and hypertension. Has been sent for colonoscopy several times by the primary care physician, but so far has not been able to do it because it's working, doesn't want to lose 1 or 2 days from work. It's referred by a colonoscopy by the PCP. We get him in our colonoscopy and navigation program for colonoscopy. After the referral gets a call from our non-clinical navigator, goes to the patient. She tries to capture as much as possible what are those barriers that we're going to encounter, and then try to figure it out what things we need to do to make sure that patient gets to screening. And that screening could be colonoscopy or stool-based screening. He gets to screening after he was found to be a high risk. He's enrolled in navigation and gets the colonoscopy. Next one. Usually the steps that the navigator goes through is education about the importance of colonoscopy. Why do I need to get this test done if I really feel well? I don't have any symptoms. I don't want to do anything. So education is part of it. Why do you need it? How can you prevent cancer or early detection of cancer? I need a job letter. Someone has to tell my boss that that day I can't work. So we do that for them. Transportation. Most of them have transportation, but it's a big barrier. So we have a way to get transportation for them, even if they get sedation. They go with a chaperone. Preparation, taking the prep for the colonoscopy is very important. So the navigator works with a plan that we design to overcome most of those barriers. So finally, he can get the colonoscopy. The patient got the colonoscopy and it was found to have an ascending colon cancer stage 3, which means now he needed surgery, he needed adjuvant chemotherapy, and after that, surveillance. Next one. Next one. For a disease that is preventable. This is how cancer looks like. Colon cancer is one of those cancers that no one ever look at it unless you're a surgeon doing it. It's not like a skin cancer that you can see the cancer on the skin, or breast cancer. Sometimes you can feel something, but colon cancer, you don't see it. And sometimes you don't have symptoms. It starts as a very small polyp. Next one. And then start getting larger and start looking more like cancer. And then next one, until it becomes a large ulcer, which is kind of the case of that patient, where the cancer is not only in the colon, but has gone to the lymph nodes. And that's what we want to prevent, because we could have found that cancer in this stage when maybe it wasn't cancer yet, it was just a polyp that we can remove, and then would have pretty much saved that patient from surgery, chemotherapy, and all the treatments that are going to be needed. Next one. And this is what we want to prevent. Advanced disease, the cancer going to the liver. Because at this point, there's not too much we can do. We can do some liver resections, but once the disease is too advanced, there's not much we can do. Next one. And we know, next one, there is a correlation between stage and survival. So if we can find that patient when they are stage 2 or early stage 3, we know those patients are going to do much better than if they are stage 4. When they are stage 4, look at this 5-year relative survival rate is 20%. If they are 3V, 50%. If they are 3A, 67%. But if they are stage 1 and stage 2, it's around 180 to 100%. So you're going to have from 10 patients, 8, 9, or 10 of them are going to be alive 5 years later. So there is an impact, it's real, and this is what is important to capture some of those patients early on. Next one. This is another case. A 62-year-old female, she's from Laos. We have it's not large, but we have a Southeast Asia community here in Providence, Rhode Island. Doesn't speak English, lives with a daughter who speaks English, currently not working. She is insured on the daughter and sent for colonoscopy after episode of blood in the stools. Patient is identified has a high risk at the navigator. Navigator does the initial evaluation. We use interpreter in that case because we don't have a Laotian speaking navigator. And we involve the family because based on our, we work with Southeast Asia Association, and they have given us some cultural sensitivity training because we see a lot of these patients, and involving the family is important for them. So next. The patient undergoes a colonoscopy. Sigmoid cancer is found. Unfortunately, she had liver cancer. You can see there's 2 lesions in the liver. Next one. 72-year-old female. So was found to have colorectal cancer, liver mets. Now she will need chemotherapy. As part of the previous checklist survey, she indicates the transportation issues. She couldn't get to the chemotherapy. When the son is working, she doesn't have anyone to pick her up. So that's something that the navigator can work with the hospital, try to get her a non-emergent medical transportation so she can receive the chemotherapy. But this couldn't have been identified if we don't do a survey. It doesn't flag the social worker. The social worker contact the insurance company to check if she's enrolled in Medicare Advantage plans. If that's the case, they can arrange transportation for her through the insurance company. And we have some other ways to do that. And you know, it's not easy, but believe it, when you start looking for options, you find them. Next. She's able to receive chemotherapy, and then after she received chemotherapy, she had a good response. You can see there she had a liver metastasis there in the liver. This is the liver, and this dark part here is where the metastatic disease from the colon is. And she underwent surgery for the liver and for the colon. But it was key for her to be able to finish her chemotherapy, and that's why navigation and helping her was very important. Next one. So what can we do? Well, the first thing is to identify that population and risk in our community. We have created a framework for a specific population. And I think this is very, very important. What we call population center or patient center intervention, because every community is different. And you have to try to identify what are the main barriers and problems in your community, and then create a plan that can help your patients in your clinic when they come to see you. Because the problems and the barriers they're going to have are going to be very different than the ones in a different zip code are going to have. Then you can design that community center interventions to overcome some of the barrier. It's not easy, and it's not easy to overcome all of them. But then you can also work with the American Cancer Society, the CAN, which we work with a lot, and try to create policies at the government level to help with some of these problems. Next one. In our case, we work with colorectal cancer, which is very common. It's the 3rd leading cause of cancer-related deaths in the United States. Next one. And we know there's a huge difference in terms of screening between different ethnic groups. Next one. In Rhode Island, for example, if you're Hispanic, very likely you have been only screened to the rate of 60%. If you are Caucasian, white, you probably have been up to 70, 75%. Next one. So we know there is an area there where we can improve. And our goal or our metric was, why can we not help our community to get to 80%, which is in 2018, what we all agree that could be a good target, 80%. Next one. And I'm sure a lot of you probably did the pledge, and you know, it started probably when this program started, try to get all the communities to 80% screen. Next one. But to do that, you have to identify kind of those key factors in your community: educational level, family income, race, and access to care. Next one. We know that if you are not language sensitive, meaning language appropriate, there's going to be a difference in uptake of the in this case colonoscopy. And you can see here when you speak the language, go back. Back. And when you speak the language here, you can see whites and blacks, when they speak the language, the annual screening rate was way higher than Hispanics that speak English, and way higher than Hispanics that don't speak English. So we know that this is clear. Next one. Then once you have that kind of community center care, You can establish what screenings you want. You can try to create interventions and design interventions that are appropriate for your own community. You can train your own navigators based on your needs. Next one. Next one. We know navigation works. I don't think we have to go through this again. It's an evidence-based intervention that works. Since 2008, there have been multiple randomized trials when we compare groups with navigation and without navigation, and not only for colonoscopy, but for any type of screening. Patients who are navigators will show up in a more significant way, and the no-shows will be less. Next one. And you can see here another randomized clinical trial where the patients that were navigated didn't have any no-shows. The patients that were non-navigated had no-shows. Next one. So what we wanted to do, and I use this as an example, was create our own navigation program. We identified what are the major barriers: insurance status, transportation, time, fear to the procedure, cultural rejection to the nature of the test. In men, that's something we saw a lot in Hispanics here. In Providence, they would tell you, "Oh, forget about it, doc. I'm not putting anything there." So we had to work a lot with education and the cultural part of it, and it could be done. Next one. What we did is that we created our own kind of flow chart, and once we get the referral, we do the initial barrier assessment. The navigator will call the patient and do the evaluation. Then based on that, we stratify the patient, low, high risk. And based on that, we'll decide what type of, besides education, what type of intervention we need to do, what type of services they might need. They might need further education. They might need transportation. They might need financial assistance. They might need a job letter. They might need a step-by-step review of the preparation for the colonoscopy. So all these are things that you can put in your own program and design it based on your needs. Next one. After doing this for almost 3 years, we started in 2016, stopped in 2019 because of COVID, and then restarted last year. We had 773 patients. One of the main problems we had was communication with the patients. The patient would be referred to us, but then the phone numbers don't work. So you cannot communicate back with them. And if you cannot communicate with the patient, you cannot navigate the patient. So that's a very, very difficult patient. There are some programs where you can give the patient a phone number, actually a burner is called, and then you can communicate with them. It's a federal program that actually gives them that phone number. For some reason, we haven't been very lucky with that. So we still have a huge number of patients that we just cannot communicate with them. We send them letters in the mail, we call them. So one of the things that we have done is that we make sure we have, when we get the referral, we get the phone number of family members that the patient would be okay with us calling. Because sometimes it happens that they work and they cannot answer the phone while they're working. Next one. After the 773 patients, 698 of them we were able to contact and enroll in the program. Next one. And we were able to obtain an 85% completion rate, which was higher than the 80% goal that we had. We show you that if you have an adequate program with navigation, in the case of cancer and prevention for colorectal, you can actually have a significant impact in the community. Next one. Outreach and education is very important. If you want buy-in from the community, if you want to work with them, you will have to go to them. You have to participate in outreach events. We started initially just with Hispanics, but then that expanded to Southeast Asia groups, and we start working with different non-for-profit organizations, with the Department of Health, the Partnership to Reduce Cancer in Rhode Island. But you have to collaborate with them to be able to reach the community and spread the word. Next one. What have we learned? Well, navigation program must be tailored, and that has been kind of our theme throughout the presentation, to the target population. Navigation should be done by a language and culturally sensitive navigator. The navigator could be a non-clinical person trained for that specific program. And the navigator should be the person doing the screening, the initial screening. Sometimes you can have an MA or another staff if you don't have a navigator. But if you have a navigator, a screening of those social determinants of health and the high-risk patients should be done by the navigator. And then the navigator can communicate with the rest of the team, social worker. So communication is key, not only between the staff, but also with the physicians. You have to kind of establish your program within your organizational structure, because they are different depending where you're working. So you have to kind of have that understanding. So how I'm going to create a program here that I can kind of mold to what we have. And sustainability. Once you start a program, you want to make sure you're going to continue it. A lot of them, the programs start with a grant. So you need to be thinking about that from the beginning and say, okay, if I'm going to do this, I'm going to show my metrics, and I'm going to show pretty much how much impact we had, and sometimes how we're going to save money. Because having a non-clinical navigator, which is what we use, has been very useful. So we can tell, look, you don't have to spend too much money on a nurse navigator, but we can train our own non-clinical navigator, and that person can work together with other clinical staff. You have to prove that it's worth it to do to your hospital or your institution. Next. There are challenges. It's not easy. Efforts to sustain active engagement. That happens a lot. At the beginning, everybody is excited, and then it comes down. You start having a lot of some barriers, issues. A patient didn't show up, this and that. So keeping that active engagement is very important. Something that we do is that we have a meeting, obviously, within our institution every 2 weeks. But we have a meeting with the referring docs every 2 months. Lack of adequate resources to screen the uninsured is also a big problem. Has decreased a little bit, but it's also a big problem. And that's where you have to work together with some non-for-profits to see if you can create some policies to help. Cost screening. Screening versus diagnostic loophole is one of the things that we were able to achieve here in Rhode Island, working with ACS CAN. And we were able to get a law that if you get a colonoscopy, it doesn't matter if it's a screening or a diagnostic, the insurance will cover. Because what was happening is that you get to colonoscopy for a screening, you are pre-approved for a screening, but if they take a biopsy, now it's diagnostic. And you end up with a cost, an extra cost. And that was one of the barriers we found. Some patients will say, no, my brother had one and he ended up paying this amount. And we realized that this was a problem. We worked together to create a policy to overcome that. Navigators has a sustainable resource, and work on funding is always a challenge. And support of other screening tests, such as FOBT or FIG tests, are very important. Reliable patient communication is not always easy because you cannot sometimes contact them. Next one. In conclusion, understanding colorectal cancer barriers or barriers to care is key. There are several series of steps, including patient navigation programs that can increase colonoscopy or other type of screenings. Population-centered intervention has culturally oriented patient navigation have shown to increase the screening in these minority populations or underserved populations. And development of programs should be focused and oriented to low-income, high-risk population. Metrics should be in place from the beginning to monitor progress and provide feedback. Next one. This is our group here at Roger Williams. Next one. Thank you very much, and I'll be happy to take any questions.
Thank you so much. You did a wonderful job setting the stage for the rest of our series. Our next session will talk about some of the screening tools, the workflow, the tracking, some of the best practices, but you have done a tremendous job at informing our audience and making sure that everyone understands what we're talking about and how we can address some of these barriers. We do have several questions and in the Q&A, one of which we have someone asking if there is a specific SDOH survey that you prefer to use, or do you adapt for the community needs, and how do you do that
Yeah.
risk assessment? What tool do you use?
That is a very good question. So let me tell you what we did. So we pretty much print out 4 different surveys, and from those 4, we sit down with our navigators, our MAs, and we do have a nurse navigator as well. And then we went through which one of those we could change or adapt to what we needed. There's some surveys that have too much information that we don't need. It's key for the patients not to feel they're wasting their time. So we wanted something that was short, something that will give us the information we can actually do something about. For example, for us, transportation was very important because it was one of the main barriers that we identify patients not getting to chemotherapy or not getting screening or diagnostic colonoscopy. So then we made sure that we had in the survey questions about transportation. And I think that's what I would recommend. Take 2 or 3 examples, and they're in, you can get them from anywhere. You go to Google, and actually the ACS, I think, has a survey toolkit. The minority department group is an NIH subgroup, has another. You can find multiple, and then take from those what you need, what you really need. There's no point sometimes in getting information that you're not going to use or that is not useful for you. And what you do is that you waste time, and the patients get tired of filling up too much surveys before getting to clinic.
Thank you very much. And we will be sure to share some of those resource tools in our next webinar or as part of our follow-up. And I appreciate you sharing that insight. You talked a lot about adapting to the culture, and that's one of the questions that's come up, is that it's pretty easy to find training on financial counseling or resources. But in terms of cultural competence or learning more about cultural beliefs that are going to affect how your patient shows up or how they move through the system, where can someone find more information about that?
Yes, another excellent question. So something that we have also done that was very, very helpful is in every community, there are groups. Sometimes we don't know they exist, but there are groups. For example, we have a Southeast Asian Association, and you can go to them and tell them, look, we're seeing a lot of patients from this community. We need resources in terms of cultural sensitivity. And most of the time they have the resources and they can help you, and they can help you train a navigator or staff. There is, for African Americans, there's a lot of cultural training. For Hispanics, there's a lot. When it's a smaller groups is where you start having more difficulty. For example, for Portuguese in our area, for Southeast Asian population, that was a little bit difficult. What we did is go to those associations, and they can work with you because they're interested on their members to have kind of cultural sensitivity care.
Excellent. I think if you lead with authenticity, right, and you're curious and you frame it around trying to provide the best care possible and trying to learn and be humble, there are lots of resources to help you connect better with your patients. We have some other questions. One is, who usually enters the Z code? Is it a physician? Is it a medical assistant? Is it a navigator? It's kind of a technical question, but.
Yeah, in our case, we have someone we call a scheduler. Is a person who, once I have patients in the clinic, that scheduler will help to get that patient to colonoscopy or to any other point of care. And in our case, that's the person who enters the C code. But it could be done by coders, it could be done by social worker, it could be done by any staff that has been trained and that kind of understand that part. It's not very difficult.
Thank you. Your people are so interested in what you have to say. So the next question has to do with how do you engage other clinical staff to be engaged in the screening process? And I think you talked about, right, there's a lot of excitement when you set a goal, but sustaining that excitement or commitment is a little harder. What are some successful strategies that you use?
Yeah. Something that we have done, and you need to find pretty much the right patient, the right story, is you have to make it real. So when I have a patient, and we did this at the beginning, maybe now the program is more stable, but when you have a patient that is able to get the colonoscopy, that you were able to help, that had cancer and had barriers, and you help them, once they get through that process, those are your best champions. Because not only they're going to be heard by the community, but they're going to be heard by the physicians, by the clinicians. So, and you have to find the best and more appropriate platform to share the stories so people know that you're doing something that is tangible. And when you listen to people saying, look, if they didn't do the navigator, I would have never, the navigation program would have never had the colonoscopy. There's no way I would have done it if someone who speaks my language didn't call me, explain to me why, and tell me, that I can have a alcohol-less margarita with my prep. So once you find those, patients, they can be your best ally. And I think people listen more to what people who have gone through it have to say than if I say it.
Yeah, I think you're right. The data is important, and the stories about the people behind the data sometimes are more important, because that's what touches your heart and that's what you can relate to. And I think we have time just for one more question. And the question is,
sorry, before you go to the next question, it's also very helpful when you have to request things from the administration to have those stories and those patients, because then it's more difficult to say no. I just wanted to add that.
Indeed. So the last question has to do with screening fatigue, so that if you're doing SDOH screening and your center is also doing NCCN distress screening and there's other screenings, is there a point at which there's a balance, and how do you make sure that you're asking the questions that really inform the care and not just kind of going through the motions?
Yeah, there are two things that I feel are key on that. And one is that happens. You have multiple point of contact and people is asking multiple times. Even you have patients say, well, I just did this last week. If the people or the other medical staff or even non-clinical staff, they are documenting that in your medical electronic record, you should be able to access that, so you would know which patient already did that or what information you already have. And then you don't have to repeat it. That has been the only way we have been able to decrease a little bit that survey every single time patient comes. So it will be important to know who else is doing the surveys and making sure that they are uploading that information in the medical record system, because most of the time you all have access to the same medical record systems. Very unlikely it's different ones. And then you can check that before the appointment, and you can say, oh, this patient already filled it up. We already have ICD-10 diagnosis for him. We don't need to survey him again or her.
Excellent. Thank you very much. Communication certainly is key, and being part of the same team and having patients know that you're all part of the same team certainly makes a huge difference in terms of trust within the system, which in and of itself can sometimes be a big barrier. So in the chat, we have lots of positive feedback. People are very sending their kudos for your presentation. And Megan, if you go to the next slide, we'd like to remind people that this was the first one in a series. The next two are going to be on January. It's very busy in the next 6 weeks or so between all of the winter activities and family activities sometimes that come up in November and December. And if you'd go to the next slide, we would like to thank all of our sponsors: AstraZeneca, Janssen, Pfizer, Bristol Myers Squibb, Glasgow, SmithKline, Novocure, Daiichi Sankyo, and Santa Fe. Without their support, we would not be able to bring you all of this excellent content. And again, Dr. Calvino, thank you very much. Fabulous presentation.
You're welcome.
And we appreciate you taking the time and are grateful that you shared your knowledge and passion with us. So thank you, everyone. Have a wonderful afternoon.